Hi, I'm Mary Ann Smith, and today we're going to talk about age-friendly healthcare and systems, an overview of the 4Ms. Our goals for today are to talk about what age-friendly healthcare is, why it's important, and then offer a brief review of how to use the 4Ms. I'd like to emphasize this is an overview. There are 8 additional programs in this series, and these programs are co-sponsored by the Somé Center for Gerontological Excellence and the Geriatric Workforce Enhancement Program at the University of Iowa Geriatric Education Center. I'd also like to add that the content is based on age-friendly initiative of the John A. Hartford Foundation and co-sponsored by the Institute for Healthcare Improvement, or the IHI. We really hope everyone will visit the website listed on this slide. So let's talk about it. What is an age-friendly health system? That's where every older adult gets the very best care possible, experiences no health-related harms, and is satisfied with the health care they receive. In age-friendly health systems, value is optimized for everyone. I mentioned earlier in the title that we're going to talk about the 4Ms. So let's start there. We have what matters most to the person. So the first M is what matters most. The second is medication. Third, mobility. And fourth, mentation, which includes dementia, delirium, and depression. I'd like to emphasize this is a framework for thinking about how we provide care to older adults, not a program. It's a shift in how we think and how we provide care. There are really lots of good reasons to use the 4M framework. First of all, it's best practice across a diverse range of healthcare settings. Second, it focuses on the person, not their disease and not their morbidities. And it also focuses on their quality of life, not necessarily more treatment or more transfers to an acute care setting or hospital. Now, that's not to say that we don't care about the many morbidities, the many health conditions that older adults have. Quite the contrary. The point is to make care for older adults with multiple chronic conditions less fragmented and burdensome, better focused on what really matters most to them, and less frustrating for the healthcare team. There are a lot of critical interactions among the 4Ms, as we show on this diagram. It all starts with what matters. What matters is the driver, so to speak. And then we think about how medications and mobility and their mentation, their overlapping, perhaps dementia or delirium and depression, all interact with one another to help the person do what matters most, or how that might get in the way. So what matters most? What does that actually mean? Well, by definition, by IHI and the John A. Hartford Foundation, that's to know and act on each older adult's specific health outcome goals and care preferences across settings. And I'd like to emphasize the words health outcome goals and care preferences. And that means it works across all of the settings that are listed on the slide. It isn't, restricted to a hospital setting or an outpatient setting or senior living. It works in every care setting that an older person might be found. So let's think some more about what matters most and that notion of a health outcare goal, because we get hung up, I think, a lot of times thinking about health care, which is the treatment and care of diseases and illnesses that a person has. But the 4Ms switches that around and says, well, that's one piece of the puzzle, but let's also think about life and living. What gives us joy? What brings us happiness? What offers meaning in living? And then let's think about our health outside of the healthcare system, our ongoing health concerns and conditions. And as this picture tries to capture, those things all interact to result in the older adult being able to do what matters most. So life and living, their health, and also their health care. So let's start with life outside of health. It's really important for us to think about when the context of what matters. So these are the questions that we might think about asking the older person. What's most important to you? What brings you joy? What makes you happy? What do you worry about? What are some of the goals you hope to achieve before your next birthday? What would make tomorrow a really great day? What else would you like us to know about you? So we take those ideas and about what matters to the person, the context, and we anchor it to their health. And we think about their health status and their care needs, and particularly at the time of a new diagnosis or treatment decision, or change in their health status, or perhaps a change in their residence or care location. And we focused our question on how treatment could facilitate or impede activities to do the things most enjoyed or to attain a goal. So back to our health outcome goal. The guiding questions, I think, are listed on the slide here, but it spins around the idea of what are the things that you would like to do. So what is the one thing about your health care you most want to focus on so that you can do more easily or more often the things that are most important to you? What are your most important goals now? And as you think about the future of your health, what concerns you most when you think about your health and your health care? And that varies. Those questions, how we phrase that, how we think about that, that's going to vary from situation to situation, care setting to care setting, when people are in the hospital or moved into a post-acute setting for rehab or in a long-term care situation, and particularly at end of life. But in each one of those situations, the question spins on what is the goal to do what? What matters most? To regain abilities, to do what? To maintain abilities, to do what? To best assure what is avoided or achieved. So the 4Ms really does focus on what matters, and then we think about mobility, medication, mentation, including possible dementia, delirium, or depression, and how that impacts the person's ability to do what matters most. We use two main steps, which are to assess each M and then act on each M. And it's very important, I think, for us to do each of those steps and not make assumptions about what we think we know about what is important to the person or what they can or cannot do, how they feel, what their mood is, or what their level of confusion may be. So let's go back and start now with a little jump into medication. So that's all about what matters. Now let's talk about medication, the next step. So when we're assessing medication, we're thinking about high-risk medications. You know, the Beers criteria, the drugs listed on the slide here, the drugs that tend to get older adults into trouble, either by drug-drug interactions or adverse side effects, increasing the risk for falls, all kinds of black box warnings on antipsychotics. So there's a lot to think about with high-risk medication and how we would like to avoid that when we're thinking about older adults. So in an assess, we look at what they're using. In and on an act on, we think about how can we recommend using medication that doesn't interfere with what matters most to the older person, their mobility or their mentation. We also think about how to deprescribe. I think a lot of us think about older adults and how many medications they take, and one is added on top of another without really giving a lot of thought to how we might want to stop and give fewer medications. So do dose reductions and discontinue medications based on what the person's goals are. Thinking about, again, what matters most and what their desired health outcome is. There are indeed times that less is in fact more. Moving on, mobility is very important, and by definition, that would be to ensure that older adults move safely every day in order to maintain function and do what matters most. And there are several recommendations about how we can, in fact, assess mobility. On the side of what do we want to encourage or act on, I think it's very important for all of us to think about assuring that older adults have a safe environment, that they have daily mobility goals that support doing what matters most to them, that we think about avoiding those high-risk medications and make referrals to physical therapy as needed to assure that mobility is maintained and sustained, and that there is a request that each one of us have regular exercise, no matter what the level of exercise is. So every day we should all be doing something to assure that we maintain our mobility. So on the side of mentation then, that is to prevent, identify, treat, and manage dementia, depression, and delirium across settings of care. In acute care, we tend to focus more on delirium or acute confusion. In outpatient settings, there's a greater emphasis put on depression and dementia. And I would like to add, in senior living, we tend to pay attention to all three of these phenomena: dementia, depression, and delirium. So let's start and talk about dementia for a minute. So the first thing I think is important to do is to check the history related to their cognitive function. Check it out. Do they have an existing diagnosis? And if not, then let's think about what is the possibility that they might have some cognitive decline or impairment. And in that, then we would like to assess their level of function using a screener like the Mini-Cog or the 6-item screener. Or if we think that they really do have a dementia, then we might want to use the St. Louis University Mental Status Exam or the SLUMS, or maybe the Montreal Cognitive Assessment or MoCA. The point is, we should know what the person's level of cognitive ability or impairment actually is. Now, when we think about dementia, I think it's really also important on the side of acting on that memory deficits don't rule out making decisions about what matters to the person. Older adults, even with cognitive decline or impairment, have the ability, the capacity to make a lot of decisions. It's important for us to respect that and to ask about their preferences and to focus on their abilities. What can they continue to do, not their disability? And throughout all of that, we want to focus a person-first approach, supported by family involvement. The next D in the 3 Ds is delirium, and that's acute confusion. And it's important for us to remember that acute confusion can be caused by a lot of medical conditions, infections, pain, low oxygen or hypoxia, dehydration, and again, there those medications are, medication side effects. So it's important for us to think about assessing the context. What is the acute confusion? Does it possibly overlap on cognitive decline, or is it a standalone? So there are lots of really great options in terms of short scales that can be easily administered, including the Ultra Brief Screener, or UB2, 2 items, 1 question about confusion assessment, delirium observation scale, or the DOS, and the confusion assessment method. And in a later program, we talk about each of those scales in more depth and detail. On the act-on side, it's really important for us to not only identify delirium, but to work really hard to treat and reverse the underlying causes. We want to make sure that people maintain their safety, gently reorient them to where they are and what's going on around them. Definitely increase their hydration, more fluid, more drinking, make sure that that dehydration factor isn't weighing in on their confusional state, and also helps with their infection if that's part of the problem. And we want to promote sleep. Certainly in delirium, we always want to try to increase ambulation. So there we go, circling right back to mobility. The third D is depression. And in depression, although I think a lot of us tend to think about being sad, blue, really unhappy, it's important for us to remember that in late life depression, anhedonia, or loss of ability to enjoy usual activities, diminishes. So people who are in later life, in particular, can have clinical depression without feeling sad or blue. Instead, they just don't feel like they can enjoy things anymore. So again, it becomes very important to assess depression. We can use the 2-item Patient Health Questionnaire, or PHQ-2, that focuses on the 2 cardinal symptoms of depression, which is prominent dysphoria or sadness, and anhedonia, or loss of ability to experience pleasure in usual activities. That's a really good starting point. And if we think that person maybe needs further assessment, we can go on and use the additional 9-item patient questionnaire that has 7 additional questions that reflect the diagnostic criteria for major depression. Another really great screening tool is the Geriatric Depression Rating Scale. So there are lots of really good options for assessing depression. And then on the side of acting on depression, there's so many things that we can do to advance health and well-being among older adults, short of giving medications. There are activities like behavioral activation, which is scheduling pleasant activities, talking therapy, including brief problem-solving therapy. Physical activity and exercise are also known to be very effective in treating late-life depression, and certainly encouraging self-care activities, including better nutrition, getting enough sleep, and managing pain is really important to addressing late-life depression. And certainly there are a long list of antidepressant medications that can be prescribed safely and effectively to reduce clinical depression among older adults, so that, again, they can do what matters most to them. So the 4Ms is a package. We don't do these things in silos. We think about first what matters most to the person. We check out risky medications, deprescribe if that makes sense. Make sure that we don't add any new medications that aren't wanted or needed. Think about mobility and how that person might exercise safely every day, no matter what their functional status is. And we want to think about their mentation, their cognitive capacity, their risk for acute confusion instead of or on top of dementia, and certainly their level of depression. And we want to think about how those things all interact in order for the person to continue to do what matters most. So I would conclude by saying the 4Ms is a series. This is an overview program, not intended to give you a deep dive into any one of the topics, but to give you kind of the big picture of how the 4Ms work, why we think they're important. So I would invite you to please also see our additional programs. One about what matters, another about medication, the third about mobility, and then 3 independent programs for mentation, including dementia, delirium, and depression. We would really like everybody to understand and use the 4Ms framework to guide their care of older people. And I would like to say it is a team. It is a team of people who all collaborate to make this work. So teamwork is essential to delivering high quality care using the 4Ms and in all situations. So again, in summary, being age-friendly and using the 4Ms makes good sense in all settings, from acute care and hospital to the ambulatory care and the clinics, in senior living and home health care. The point is to always focus on what matters most to the older person. Then think carefully about their medication, their mobility, their mentation, and how those things interact to impact whether the person is able to do what is truly most important to them. Another secondary aim is to really reduce unwanted and unneeded care and treatment. The goal is to let the person be the driver by asking them, what matters to you? What is your healthcare goal? What makes life worth living to you? So the goal is to promote quality of life and living, and sometimes truly, less is more. Thank you.